Hello everyone. Let's discuss the outcome of the clinical case of this week. So if you go back to the first video where we presented this 2-year-old female spay domestic short hair with a 6-week history of obtundation, and then 2 days prior to referral, the cat deteriorated and developed clinical signs associated of leaning towards the right. It had a right-sided head tilt, it had the right positional strabismus, pathological nystagmus with poor position deficits on the left. So the question that you had to answer is, where is the neurolocalization? And the neurolocalization, to explain this clinical signs, it has to involve the central vestibular syndrome. And then, do you think the lesion will be more on the right side of the brain or the left side of the brain? And to explain all these clinical signs together, the lesion must be in the left side of the brain. And therefore, why we have these right-sided vestibular signs but a left poor position deficits, and this fit with what is known as the paradoxical vestibular syndrome. And I want briefly to just discuss, when we talk about the normal function of the vestibular system, we have our inner ear, where we have our vestibular apparatus, then we have with our vestibular nuclei in the medulla oblongata, and then part of the cerebellum that also has vestibular function, which is the flocculonodular lobe. And the cerebellum, that part of the flocculonodular lobe, communicates with the vestibular nuclei by the caudal cerebral peduncle. So, talking about the electrical inputs, we have constant electrical activity sent from those receptors in the inner ear belonging to the vestibular system, and send that electrical input to the vestibular nuclei, and that is controlled also by the inputs from the cerebellum. And remember that all the inputs that come out the efferent from the cerebellum will always be negative. So we have positive coming from the inner ear, negative coming from the cerebellum. We are in a balance. The cat or the dog will not have any vestibular signs. However, if we have a lesion affecting the vestibular system, really doesn't matter if it's central or peripheral. Remember that the vestibular signs will always be towards the site of less electrical activity. So if we have a lesion either affecting the inner ear or affecting the vestibular nuclei, we don't get that positive electrical activity, but on top we get that negative input from the cerebellum. So which is the site of less electrical activity, this side. So the cat or the dog will show vestibular signs leaning and falling towards this side. So in somehow you can say, okay, vestibular signs are always ipsilateral to the site of the lesion, but there is an exception to that, and that's the paradoxical vestibular syndrome. So why this is happening? Because if we have a lesion either affecting the flocculonodular lobe at the level of the vestibulocerebellum or the caudal cerebral peduncle, we're not able to inhibit those vestibular nuclei. So we get positive and positive, the other side that gets the negative from the cerebellum, and that side continue to get the positive. So which is the site of less electrical activity? This one now is the site of less electrical activity. So the clinical signs will be contralateral to the lesion, while the lesion will be obviously on this side. In this cat, we did not see obvious cerebellar dysfunction, but we had postural reaction deficits. Our proprioceptive pathways are ipsilateral at the level of the medulla oblongata. So we can say, particularly in this case, that we had a lesion affecting the left side, particularly involving the caudal cerebral peduncle. And hope this is clear, and maybe a little bit fast. You can replay this if you want to discuss this, or you have any further question, please tell us. But then, should you be worried? And if we have to present this case based on the clinical reasoning, what do we have? We have a chronic, progressive, lateralized, not really painful left cerebral peduncular lesion in a 2-year-old female spay domestic short hair. So we have, when we talk about the etiological diagnosis, we should think about inflammatory neoplastic as very high on the list, and then obviously we can also consider some anomalous, but less likely. You had a beautiful presentation of the MRI findings and by Fraser that was posted on Wednesday. But if we talk about the differentials, we have infectious inflammatory disease, lymphoma, medulloblastoma, or meningioma. What we saw in this cat, it had severe increase in intracranial pressure with herniation of the vermis through the foramen magnum. And to reduce the intracranial pressure, we gave intravenous mannitol to reduce the perilesional edema, the type of vasogenic edema that was seen on MRI. And also we gave intravenous dexamethasone to also help to decrease the vasogenic edema. Interestingly, we ran Toxoplasma gondii titles. It was consistent with an active infection. It had high of IgA, and the cat was started on clindamycin and prednisolone also to continue to reduce the perilesional edema and to control the potential inflammation due to the protocytes death due to the clindamycin treatment. So the cat came for a recheck at 11 weeks and been 11 weeks on clindamycin, and the cat returned to normal. So when we evaluate the mental status, it was back to normal. The neurological examination did not reveal any neurological deficits. So we perform a follow-up MRI, and interestingly, the lesion totally disappears. Is fascinating how the structure of the cerebellum and at the level of the caudal cerebral and also the degree of increased intracranial pressure, showing the herniation of through the foramen magnum, everything has returned to the normal MRI appearance. So what can we say about this? Based on the literature, prior to this case, the Toxoplasma gondii granuloma has been diagnosed with biopsy. But what we publish on this case, and if you want to read further about this Toxoplasma granuloma in this cat, obviously we could not add confirm because we never get we didn't get the histopathology, but the fact that totally disappear on the clindamycin treatment and the Toxoplasma titers were consistent with an active inflammation is very consistent with a Toxoplasma granuloma. So in this case, is the learning is obviously biopsy is not needed in these cases if you have highly suspicious that this cat or that particular cat has an active infection. I hope you enjoy the case, and if you have any particular question, please do not hesitate to ask. Thank you.